system. Surgically, one has to have a support of amniotic membrane, mucous membrane grafting, a slet, K-Pro, tenon patch graft, as well as these days the cultured oral mucous epithelial transplantation. This is the MMG, and then of course your glaucoma, oculoplasty and retina colleagues are equally important in co-managing these conditions along with the referrals to rheumatologists and dermatologists. So most important takeaway points here are diagnose and find out the etiology of your CCC, be in connection or be in collaboration with the ocular surface surgeons, document the progression as much as possible. Conjunctival biopsy usually helps a lot, and correct and early diagnosis prevents blinding cicatricial sequelae. Thank you so much.
Thank you, Purvasha, for a comprehensive CCC presentation. And Dr. Sushmita Shah will be next. Double to trouble, infections in OSD.
Good morning, everyone. I thank AIOS for this opportunity. So if you're not scared by the cicatrizing conjunctivitis, there is more trouble for you. So coming to my talk, which is double trouble, infections in ocular surface disease. So I was trying to list down what all would come as ocular surface disease, and this is what I came down to: ocular cicatricial pemphigoid and SJS, Sjogren's syndrome because of various causes, and many of the miscellaneous causes which include various causes that lead to LSCD like post-chemical injury, aniridia, graft versus host disease, atopic keratoconjunctivitis, blepharitis, and also Meibomian gland disease. Now, pathogenesis, various studies show an incidence of between 2.98 to 3.5%. The basic problem is an impaired ocular surface immunological defense mechanism. So you have abnormal tears which are deficient in the protective factors like the tear lysozyme, lactoferrin and IgA, and you also have high concentration of inflammatory cytokines in the tears. In addition to this, the surface is abnormal with abnormal epithelial transdifferentiation, basal epithelial cells mitosis, epithelial disruption, gycoclylix instability and abnormal surface mucin. Now chronic use of antibiotics, and sometimes some people also use steroids, leads to an alteration in the ocular surface flora. Now the local the local ocular predisposing factors include, just like I mentioned just now, topical corticosteroid use, contact lens wear, various lid abnormalities like lid malpositions, trichiasis, lid margin keratinization. Even severe dry eye is one of the predisposing factors towards infections in dry eyes, and various surgeries. Now, one of the older papers mentioned that if a patient of OCP is not on proper systemic immunosuppression, that can also make the person more prone to having infections. And systemic NSAID use, this paper is from Epicenter, which says that there is stronger association with chronic severe ocular surface complications in eyes with cicatrizing conjunctivitis. Coming to management, where first you have to ascertain the diagnosis of OSD. The reason I've written this is because some of the patients may not be your old patients. They might be somebody new which has been referred to you, and the primary ophthalmologist may have missed the diagnosis of the OSD, which was in the background of the microbial keratitis. So you need to not miss that the surface, not just a microbial keratitis, but also an ocular surface disease. Look for all the top, local predisposing factors. Now, microbial keratitis, as we know, corneal scraping is the mainstay in the first step in the diagnosis and initiation of treatment on initial smear reports. Unfortunately, outside many times the microbiology backup is not great. Nonetheless, corneal scraping is an absolute must. If you're suspecting herpes simplex virus, then one could also try PCR. Now, there are multiple reports of the use of conjunctival swab because the conjunctiva is abnormal, and you may have all kinds of bugs which you otherwise don't see. But what has been mentioned is that the conjunctival swab report does not correlate well with the causative agent of the microbial keratitis, so it clinically may not be very relevant. One must also look at the systemic status, like diseases like diabetes mellitus or any kind of immunodeficiency status, and also presence of collagen vascular disease, because these are also going to be the Sjogren's syndrome patients. Status of the immunosuppression, systemic immunosuppression like steroids and other immunosuppressive agents. The commonest organism which has been reported is gram-positive cocci, mostly Staphylococcus, this coagulous negative staph as well staph aureus. The second in line are the gram-negative bacilli, Pseudomonas. Herpes simplex virus has also been commonly seen. Now one thing which is different as far as fungal infections in ocular surface disease is concerned is that there has been noted to be a higher prevalence of candida as compared to filamentous fungi that we otherwise see, and also polymicrobial infections are more common. Now the bacteria show low susceptibility to antibiotics with high incidence of methicillin resistance. Antimicrobial therapy also should be based on the smear report. Now in bacterial gram-positive infections, the options are monotherapy with fluoroquinolone versus fortified first-generation cephalosporins. The study from Australia which says that the outcomes following use of first-generation cephalosporin is worse because the surface toxicity of that is almost 5 times more than 4th-generation fluoroquinolones like ofloxacin and the moxifloxacin. The second line drug could be chloramphenicol, and it's been recommended that you could switch once your patient starts responding. That could also be the second line. Vancomycin has shown excellent in vitro susceptibility, especially because these are many of these are MRSA. And if you're suspecting herpes simplex virus, which usually is clinical diagnosis, one should go for ganciclovir ointment, and for candida, voriconazole eye drops. Now, we also need to very importantly manage lead conditions like trichiasis or some kind of leg of thalmus, etc. Otherwise, the ulcer is never going to heal. And also, please have a very close focus on the formulations and their surface toxicity. Now this is a chart which enlists all the various large studies reporting infections in ocular surface disease. The biggest study is from RP Center by Dr. Sharma et al., which shows about 83 patients, all with either SJS or 10, and with the highest number of positive culture, it was 30%. Now, here they do report a higher incidence of polymicrobial keratitis as compared to the general population, but the other two studies, the one from LVPI, which does not show very high polymicrobial disease, but they show very high fungal infections, and the last study, which is from Taiwan, show very high incidence of polymicrobial as well as fungal as compared to the general population. And all three studies, the most commonest organism was Staphylococcus. Now coming to complications, the non-healing epithelial defects, recalcitrant infections, desmetocele, corneal perforation, and rarely endophthalmitis. So treatment of non-healing epithelial defect, we need to modify to less toxic drugs, adequate preservative-free lubricants. If there are lead issues, then tarsorrhaphy, lateral or a paramedian will also be very useful. If you have access to autologous serum drops, that also helps. And amniotic membrane grafting, very invaluable in persistent epithelial defect. This was a gentleman with a large non-healing epithelial defect in SJS, patient who had to travel abroad. So we just put 2 layers of amniotic membrane double layer AMG using fibrin glue, and this seemed to work very well. I'll just put one more layer. And this really helped in, I'll just move on. This was another young male with SJS and a small ulcer, which was again a negative on microbiology. He started on 4th generation fluoroquinolones, healed, but it started resolving, but perforation, but the thinning increased. So we did an AMG and did very well. Vision improved from finger counting to 6/18. Now corneal perforations, second-related complications. Now this chart by Kate et al. Enlists very well how to treat perforations in dry eyes. Cyanoacrylate glue for smaller perforations, and infection is subsided. If it's larger perf, you could do a multi-layered AMG or a cortinon patch graft or even a corneal patch graft. If it's a recalcitrant microbial keratitis or a larger perforation, usually more than 6 millimeter, they have no choice but to do a therapeutic keratoplasty, though we know that the outcomes are very, very guarded. Now this is a representative video of a tenon patch graft. So this was not a patient with a neurotrophic keratitis. I'm just trying to show the video for the technique. The tuck-in technique is being done. So this is the tenon which has been harvested from the, and put it there into the tuck that we have created. Now this is fibrin glue being used to fix the tenon patch. Now this, since it's a large perforation, it is usually recommended to use a amniotic membrane on top of the tenon, and that is also secured. And then we put the cross sutures. I'll just fast forward this. And close the donor site with glue, and the last is the AC reform. And
Thank you, Dr. Sushmita. Again, we've given everyone fairly large topics to cover in a small amount of time, so everyone's doing a great job. Ikeda now on acute chemical injuries, pearls of management.
A very good morning to all. Can I have somebody to connect the HDMI port, please? All right, so I would be talking about acute chemical injuries. So we know that these are true ocular emergencies, and out of all the ocular injuries that we encounter, 10 to 22% are chemical burns, and they affect the young male population more than the females, and 20% of these can lead to significant cosmetic and visual disability. So just going over the different alkali agents that we see, I will just like to highlight that lime is more frequent in our country, and although because it forms a particulate matter, the penetration is lesser, but it tends to get coagulated in the upper fornix, and therefore eversion of the upper lid is very important to look for residual lime particle when we are treating cases with lime injury. Now, amongst the acid, the most dangerous is the hydrofluoric acid, which can penetrate very easily, and there are different compounds that have been used as an antidote, like calcium gluconate, to take care of patients who have hydrofluoric acid burns. This is one of the true ocular emergencies, and the dictum here is that treat first and examine later. All we need to do is do a quick examination to rule out open globe injury, and then proceed with copious irrigation with the cleanest fluid that we can easily access, is easily accessible to us. And like I mentioned before, double eversion when we are irrigating the eye is important to look for any residual particulate matter. If we have litmus paper strips with us, it helps to check the pH from the ocular surface. Now, the most common classification that we use here is the Duas classification, which is based on the extent of the limbal involvement as well as the bulbar conjunctival involvement. A few fallacies that we have in Duas classification: it does not talk about the scleral ischemia and the intraocular pressure, but it helps us in clinically assessing the severity of the chemical burn for us. So if you look at the major principles in management, first and foremost is re-establishment of a corneal epithelial surface, rigorous control of the inflammation that occurs in these eyes, and must not forget intraocular pressure that needs to be monitored. So let's look at a few cases now. This is a grade 1 chemical burn. We don't have any involvement of the limbus. There is no stain taken up in the limbus. And this is a grade 2 burn, and staining helps us in actually assessing the extent of the epithelial defect both on the conjunctiva as well as the cornea, and these can be managed usually with medical management alone. So the medical management essentially consists of topical steroids, which need to be frequent, and depending on the grade of the injury, we can decide how frequent topical steroids we need to instill initially. This helps in controlling inflammation, and cycloplegic eye drops for symptomatic relief. Antibiotic eye drops as a prophylaxis against infection, and we can use lubricant eye drops as well as ascorbate to support the process of repair and promote epithelial healing. So if you look at this case of grade 1 chemical burn, this healed in the next 4 days just after medical management. Now this is a grade 3 burn. We can start initially with medical management, but we have to assess the healing and stain the surface and call the patient frequently for follow-ups, and they might require surgical management if it does not heal. This is a more severe variety of burn. This is a grade 4 chemical burn, and these cases usually require us to intervene surgically, and we know that amniotic membrane graft helps us in essentially promoting epithelial healing and also providing symptomatic relief. So here we'll just go over the amniotic membrane graft here. What we need to do is cover the ocular surface and use fibrin glue on 2 different syringes, which makes it easier for us to apply the fibrin glue, and we deflect both the surface from the amniotic membrane graft and iron the glue out and secure it in position. We could use a suture on the side if we need, and if we feel that the amniotic membrane is not going to stay, or use a BCL on top. And these cases, especially if we have inferior signs or if we have signs of exposure, if we have a large epithelial defect or inferior limbal ischemia or scleral ischemia, tarsography helps greatly in preventing the amount of exposure, and also since the tarsal conjunctiva comes closer to the bulbar conjunctiva, it helps in vascularization and promotes epithelial healing. So these cases, the kind of tarsography that we need to do will again depend on the severity of the burn. So here we are doing a lateral paramedian tarsography, but some of these very severe burns might require a central tarsography to promote the healing. This is the same patient followed up after 8 months, and he subsequently developed a total limbal stem cell deficiency for which he underwent SLET. Now here in this video, I would only like to highlight, this is a case of ocular surface burn, actually thermal burn, and here we need to remove the necrotic tissue that we have here. So otherwise this necrotic tissue is going to inhibit the healing, and in some of these cases, tendinoplasty or advancement of the tendons actually helps in vascularization. So this is something that we must not forget. If there's necrotic tissue on the surface, that must be removed as well, and this was followed by an amniotic membrane graft and a complete tarsography. Now, the technique of AIOC has been described by the SN group, which helps in grade 4 and above burns, and the epithelialization is faster with AIOC as compared to an amniotic membrane graft alone. So in terms of how to deal with a large epithelial defect, if the defect is less than 50%, we can go ahead with amniotic membrane graft. And if it is non-healing, that we should consider an AIOC, and patients with severe burns or large corneal conjunctival, bulbar conjunctival defects, we could straight away go either for AIOC or mucosal grafts. Now, this is a recent paper by the LVP group which highlights the importance of ischemia and the role of tendinoplasty. So here again the idea is that if we have necrotic tissue, that needs to be excised so that the vascularization can be promoted and the conjunctival epithelium grows over it. So this is one of the cases that they have demonstrated in this paper, where we can see that there is inferior scleral ischemia as well as limbal ischemia, and advancement of tenons greatly helps in vascularization. So the idea is that it prevents corneal melt, and it promotes healing of the epithelial surface. But this is useful in severe grades of burn. So this is the dictum that has been proposed. So if we have specially delayed presentation more than 1 week with clear areas of ischemia, then if we have access to anterior segment OCT angiography, this will help us in assessing the amount of limbal ischemia, and tendinoplasty would greatly help in assessing this and going ahead with the procedure. So to conclude, these are true ocular emergencies. Initially, for these cases, we need to start frequent topical steroids to take care of the inflammation. The things that we need to look out for are monitor the epithelial healing, the scleral ischemia, as well as the intraocular pressure. And the techniques that we have in our armamentarium, which we need to combine and choose for different cases, include amniotic membrane graft, AIOC, tendinoplasty, and tarsography. Thank you.
Thank you, Dr. Lal. Just for the Indian audience, when we talk about tuna particles, we have to differentiate. Would you like to talk about a couple of words about the difference between the edible tuna and the plaster tuna distemper? When we see tuna injuries, there are two forms which we see. One is the tuna or the calcium hydroxide used for painting surfaces. That comes mostly in liquid form, which one can irrigate away easily. But unfortunately, there is another form of tuna available, or calcium hydroxide, which is in paste form, which is edible form. And if that gets into the eye, the scenario is very different, because it actually stays like a depot in the eye and in the fornices. So when a patient talks to us that they got tuna in the eye, we need to differentiate whether it's edible tuna or whether, because they take it as the same, but the behavior is quite different.
And especially in the packets that it comes in, which can burst open and then
yes,
get
so the
retained
packet
in the
generally, the funny thing, or the unfortunate thing is that the people who actually use those things, they are aware of the dangers. So it generally happens to the bystanders or the attendants of someone. You ask someone to fetch that packet of tuna, and it's like a soft squeezy ball. And if I give it in your hands, you will also try to just squeeze it, and it bursts with the force, and it squirts it generally into the dominant eye of the patient, and implants it in the fornix.
Unfortunately, most of these, what you call bystanders, are kids who have been sent by parents and uncles for the pawn shop. Yeah. Unfortunately.
Grandparents have sent those.
Thank you. And I invite Dr. Shizuka Ko, who is no stranger to AIOS from Japan, on a novel approach to dry eye diagnosis. The Japanese Ophthalmic Cornea Society has their own way of grading dry eye using fluorescein patterns, and we look forward to hearing from her.
Thank you for the kind introduction, Dr. Mascati. Hello, everybody. This is Shizuka Ko from Osaka University, Japan. It is my great honor to be invited here to give a talk. My talk today is about the dry eye diagnosis. I'd like to introduce the novel approach to diagnose with just a fluorescein. Okay, this is my financial disclosure. I believe all of you are familiar with this report. So first, it was published in 2007, and later, 10 years later, another version was published. Right now, several reports are actually published in progress. Let me introduce the Asia Dry Eye Society. It was founded in 2014. And based on the changes in the understanding of the types, symptoms, and signs of dry eye, actually ADES proposed a new perspective about dry eye. So this is a timeline about the definition and diagnostic criteria for dry eye for both TFOS and ADES. So ADES define dry eye in the following. Dry eye is a multifactorial disease characterized by unstable tear film, causing a variety of symptoms or visual impairment, potentially accompanied by ocular surface damage. So this is a simple comparison about dry eye definition between those two and the ADES. Actually, according to those two, dry eye is characterized by multiple potential pathogenesis. But for the ADES, it is very simple. It is characterized by unstable tear film. This is a pathological mechanism. Actually, there are a lot of risk factors for the causing underlying mechanism of dry eye. Static risk factors include abnormality in lipid, aqueous, and mucin components. For the dynamic risk factors, there are a lot of known dry eye-related conditions, you know. So based on the abnormality in tear film or epithelial surface, ADES classified dry eye into 3 types. So in aqueous deficient dry eye, target component is aqueous tears. In the decreased wettability of dry eye, the target component is the mainly membrane-associated mucin. And increased evaporation dry eye, target component is generally lipid layer, mostly associated with meibomian gland dysfunction, MGD. Of course, there are mixed type of dry eye may exist. So let me, okay. So actually, according to the ADES, dry eye can be diagnosed with a combination of symptoms and unstable tear film. This is very simple. And it is highly dependent on tear film stability. But actually, with just a simple tool of fluorescein, so we can diagnose dry eye. So let's revisit the simple 3 steps in use of fluorescein. So please apply the minimum amount of fluorescein and shake well. Otherwise, actually, extra fluid can affect tear stability. And of course, please apply gently. So just a paper strip operation helps dry eye diagnosis without any expensive special devices. So tear film oriented diagnosis, it is actually based on the fluorescein breakup pattern. We can classify dry eye into three types: aqueous deficient dry eye, and decreased wettability on dry eye, and increased evaporation dry eye. Let me explain with the movie. Okay, let's start with the aqueous deficient dry eye. So this is the area break. So this is a severe aqueous deficient dry eye. Insufficient component is aqueous tears. So there is no upward movement of fluorescein after the blink. So it is only limitedly observed within the lower part of the cornea. Usually you can see a lot of corneal epithelial damage over the cornea. So this is the line break. So this is a mild to moderate aqueous deficient dry eye. Insufficient component is aqueous tears. So you can see the vertical line-like shape during upward movement of fluorescein as the lower part of the cornea. Unlike the area break, it is actually right after the blink. There is nothing, but you can see the vertical line break, lower part of the cornea. So let's move on the decreased wettability dry eye. Spot break. Now you can see a lot of spot. Spot-like shape immediately after the eye opening, or when at least one spot break is not erased during upward movement fluorescein. It is very unique. So this is a severe decreased wettability dry eye. Insufficient component is actually membrane-associated mucin. So this is the dimple break. You know dimple. Okay, so this is a mild to moderate decreased wettability dry eye. Insufficient component is membrane-associated mucin. So you can see an irregular but vertical line-like shape during upward movement of fluorescein within the central cornea. Unlike the spot pattern, right after the blink, there is no breakup, but you can see the break during the upward movement. Let's move on. Increased evaporation dry eye, random break. So this is the increased evaporation dry eye. The insufficient component is usually lipids associated with MGD. An irregular, indefinite shape occurs after the cessation of upward fluorescein movement. So the point is you can see the breakup right after all the movement actually finished. So of course you can see these random break even in the normal eyes. So this is a summary of the TFOD, tear film oriented diagnosis. You can do that, just a paper strip operation. And let me share with you quickly about the tear film oriented therapy. So each layer of the ocular surface may be targeted by a selective topical therapy to stabilize the tear film. So this is the strategy of each pattern. So in aqueous deficient dry eye, we need the aqueous tears. For the area break, we need adequate aqueous supply, like punctal plug. And for the line break, we need rehydration. For the decreased wettability dry eye, like spot break or dimple break, we need mucin supply. But for the increased evaporation of dry eye, we need usually MGD treatment. Again, fluorescein staining is powerful. So you.
Wonderful, Shizuka.
Thank you very much.
Dr. Suzuka, can you use distilled water instead of saline? Why would you use saline instead of anything else?
For use of fluoridation, we use a saline.
Distilled water instead, that has nothing in it, right? I mean, for fluorescent staining.
Actually, some hospital actually use actually drop of fluoridation, but in my hospital I usually use a paper strip, just a paper strip of fluoridation.
You use paper strip, but can you wet that paper strip?
Yeah, of course, yes. Just usually, so I recommend put the 2 eye drops of saline, and actually with wake shell. Because in my experience, just 1 drop of saline, actually it is not sufficient. So 2 saline eye drops.
Thank you. And but we have to finish the session. So she's not speaking. Okay, so with this, I'll just summarize the thoughts, and since the last speaker, Dr. Namrata, is not present, we have a little time for the panel. So we had the first speaker, Dr. Purvasha Narang, giving us a bird's eye view of the common conditions associated with CCC, chronic cicatricial conjunctivitis, that is Steven Johnson, graft versus host disease, OCP, and drug-induced, and giving us a bird's eye view that the management is both medical, then special contact lenses like the pros, and surgical in various cases, and it's important to prevent them from going to the end stage. Dr. Sushmita told us about the various risk factors associated with getting infections in patients with OSD who are more predisposed to these infections, and she brought out important points that monotherapy is the choice, but instead of using drops fortified, which we make ourselves, which worsen the ocular surface, it's better to use commercially available fluoroquinolones, and chloramphenicol is a good second choice. And of course, for severe cases, tarsorrhaphy and double-layered AMG she showed with elegant videos. Dr. Ikeda Lal told us about acute chemical burns, and even in the acute stages, it's not only the medical management, but the grade 4 and above, you might have to do surgical treatment with with AMG in acute lesions. It's important in thermal burns, especially to remove all the necrotic tissue, because that is worsening the situation, and you might have to resort to tenoplasties in severe cases, and even allo-SLEP. Dr. Shizuka Ko, with a musical presentation, gave us the importance of a simple fluorescein strip, and how the Asian Dry Eye Society uses just the fluorescein patterns to get to a diagnosis of whether it is aqueous deficient, mucin deficient, or lipid deficient, and modulates that treatment accordingly without all the sophisticated devices that many of us in this room have. Just a word of caution, those excellent pictures that she showed are not easily replicable. We've tried, so we know that it's not easy to get those pictures. You need that yellow filter, especially to get those images, and even then, with my photographic skills, I've never been able to come to this, and of course my musical abilities are much inferior, so I wouldn't try what she just tried with us. Over to you.
Ma'am, may I?
Question I want to ask Shayan. Shayan, could you please tell us how to identify ischemia in your wonderful ocular surface workshops? We saw that, and we saw Dr. Bhaskar Roy Chaudhary's software also, but if you can enlighten us a bit.
So it's not easy, firstly. We did a study once looking at the variability that is there between different degrees of experience and different, cadres of people, ophthalmologists, optometrists, fellows, trainees, professionals, and we saw that it was all over the place. So it's not easy. Everybody has a different concept of what ischemia is. That is also because we have not seen what the eye looked before that ischemia happened. So we really sometimes don't know what to look for. So the most severe forms of ischemia are very straightforward, where you have deepithelialization, even the tenons is necrosed, and you can see the sclera straight away. Those are obvious, but more subtle forms of ischemia are difficult. But I can tell you this because we've done a lot of research with correlating with the anterior segment OCT, which was very useful because otherwise it's really difficult to do angiography. Particularly fluorescent angiography is difficult because it leaks. You can do ICG, of course. So the epithelial defect is a good marker of ischemia. Where you see a conjunctival epithelial defect, where you see subconjunctival hemorrhages, those are typically areas in which you have ischemia. Although the part of the eye may look red, which is where it becomes difficult and tricky because it's paradoxical, there can be ischemia. So epithelial defect, conjunctival epithelial defect is a good surrogate measure of ischemia. But the only caveat here is that it's also dynamic. So you need to follow up these cases. What looks ischemic today may recover very well tomorrow and the ischemia may be completely gone. And in deeper cases, the ischemia might actually get worse. So it depends on the type of chemical, the pH, the penetration, all of this. So serial fluorescence staining to see which way it is going, whether it's getting better or worse, is the best way to actually determine ischemia rather than looking at how white or how red the eye is. Because sometimes because of the hemorrhages, it is misleading because you look at a red eye and you think that there's no ischemia. It is dynamic. So some will get worse, some will get better.
Is Octa for it?
We use, OCT based angiography. Unfortunately now there are not many clinically available platforms in which you can do, but we had a small window of opportunity for 4 or 5 years using the OptoView. It was quite useful.
Did you use Dr. Bhaskara's software? Dr. Bhaskar Roy Chaudhary had made a software, I think you guys will know. Did you all use that?
The software is quite intuitive. The only problem is you need very high resolution uncompressed photographs, and where you have subconj hemorrhages, etc., again it's a little misleading there. So infrared photography is actually better if you want to look at if there's some kind of infrared imaging that can look at the vessels. But it is useful. But like I said, you don't have to do anything fancy. Just monitor the epithelial defect. If the epithelial defect is getting small, the conjunctival epithelial defect, if that is getting smaller, ischemia is resolving. If it is not getting smaller, if it is static or it's getting worse, then the ischemia is present or is getting worse.
Can I ask one question? The panel and Shayan is there and Dr. Sangwan sir is there. In case of known case of OCP, whenever we suspect the OSSN, how to deal with these cases? Known case of OCP, ocular cicatricial pain figure, and we are suspecting case of OSSN, one eye. So is this exactly OSSN? How to diagnose? The impression site will come, there is a metaplastic ulcer there. So is this so? To how to approach this patient? It will be the chemotherapy or like that, or should MMF for the given to this OCP, and or it's something muscarding.
Quickly hand over the mic to Dr. Virendra Sangwan.
As otherwise, as if there's no OCP, because see, impression cytology may not be very helpful, OSSN. Maybe do an excision, or if you are clinically sure, do a chemotherapy, topical chemotherapy for management, and continue your OCP. If it's active, continue the OCP treatment. Yeah, that's fine. Then use if surgically, if it's not very large, if you think the medically immunotherapy chemotherapy can handle, so you enter for that.
Let's go see him.
I would not know. I mean that you may have to look up because I have not encountered that situation. But I would think that you will continue in the same.
I was tempted to speak a few words on invasive.
Send the patient to Dr. Anirban Bhaduri, who is our consultant of that. He confirmed the things also. Then I have started initially I was ambiguous whether I will start the combine the things or not. But the things are doing well. And when I search for the literature, the 5 or 4 cases are there. Yeah. Thank you, sir. Thank you. Thank you very much. Thank you. I think we conclude the session because the next sessions are all waiting. We have a group photo quickly. Requesting all the speaker, Dr. Sushmita is there. Yeah, please.